Hello, my name is Dr. Kim. I'm a board-certified orthopedic surgeon specializing in foot and ankle surgery. Today I wanted to discuss ankle instability and how do you treat ankle instability. Well, I'm going to be talking about the surgical perspective, and in another video I'll go over the non-surgical perspective. So when you discuss ankle instability, there are the dynamic stabilizers and there are the static stabilizers. The dynamic stabilizers are really your tendons, your peroneal brevis to be specific, as well as your peroneus longus, which is a secondary everter. The static stabilizers are your ligaments because they don't move. So the primary static stabilizers in the ankle include the ATFL, which is the anterotalofibular ligament, the CFL, which is the calcaneofibular ligament, and the PTFL, which is the posterotalofibular ligament. Also, when you think about ankle instability, you also have to think about high ankle sprains. The high ankle sprains includes the syndesmotic complex. The way I approach ankle instability is a procedure called modified Brostrom internal brace. Now, modified Brostrom has been around for many years, but what is internal brace? That's a more newer technology. I tell my patients the internal brace is like a seatbelt for life. The internal brace protects you from injuring your ankle into the future. Also, it allows for a faster rehab. The internal brace is really made of what we call biotin adhesive screws as well as fiber tape. Fiber tape is a suture which is very strong. As you can see in this example, I'm using a fiber tape to lift up a 25-pound dumbbell, and it doesn't break. So imagine what kind of seatbelt this would provide for your ankle into the future. Surgery is really warranted for patients that have failed conservative care to include physical therapy, bracing, modified activities, as well as for chronic instability. The way I define chronic instability is ankles that just feel weak. People don't trust it. The ankle just tends to give out. Descending stairs are really hard with chronic instability. People can get other concomitant problems such as neuritis, peroneal tendon tears. Specifically, the way I approach ankle instability is a two-incision approach to address the ATFL and CFL. Aside from the two-incision approach, patients really want to know about the rehab. When can you become functional again, and specifically, when can you return to your activities such as sports? The rehab protocol is pretty straightforward. The first 2 weeks are going to be painful after surgery, so we give you a surgical walking boot, which is really as needed. The most important thing is to keep the incision dry, use the RICE protocol, which is rest, ice, compress, and elevate, and use the surgical boot as needed. After 2 weeks, the sutures are removed and people progress to physical therapy. Most patients typically get back to full activity between 4 to 8 weeks, just depending on your activity level, as well as how much rehab you will need to get back to your pre-injury state. As with any surgery, you got to think about the complications. Complications of surgery include infection, nerve damage, vessel damage, hardware failure. For more information, please visit my website, drpaulkim.org, as well as anklesprain.com, which is a website sponsored by Arthrex.com. Thank you for joining me today. I hope it was helpful to learn more about the internal brace. Now, if you have chronic instability and you've been dealing with it for more than 3 months, please do go seek a professional. Thank you, and I look forward to seeing you next time.